Hello, my name is Mohammed, and welcome to the CT Scan Academy. Today, we will discuss a rare and highly educational case involving aberrant contrast distribution during a lower limb CTA. This case represents an unusual manifestation of cardiopulmonary arrest that went unrecognized prior to the scan. It provides an excellent opportunity to understand both the radiologic features and the critical importance of early emergency recognition in the imaging environment. The patient was scheduled for a lower limb CTA. Unfortunately, at the time of the scan, the patient was experiencing unrecognized cardiopulmonary arrest. In such situations, contrast injection without prior verification of vital signs can lead to abnormal imaging findings and may carry significant clinical risk. Expected hemodynamic pathway. Under normal conditions, contrast transit through the cardiovascular system requires active myocardial contractility. The expected pathway of contrast is as follows: superior vena cava, right atrium, right ventricle, pulmonary artery, pulmonary circulation, left atrium, left ventricle, ascending aorta, descending aorta. This process relies entirely on effective cardiac pumping to propel the contrast through both the pulmonary and systemic circulations. This phenomenon is most commonly encountered in cardiac hospitals, mostly during coronary CT angiography procedures. However, this specific case was performed on a Philips Ingenuity Flex CT scanner, and I personally carried out the examination. Abnormal contrast distribution. In this case, we observed a markedly abnormal distribution of contrast. Key findings included absence of pulmonary arterial opacification, reflux of contrast from the right atrium into the inferior vena cava, passive flow of contrast driven solely by the injector rather than by cardiac output, pooling of contrast in dependent venous structures. Dense contrast was noted in the left subclavian vein, azygos vein, right atrium, inferior vena cava, and hepatic and renal veins, while there was no opacification of the pulmonary arteries or aorta. Radiologic interpretation. This pattern is recognized as the contrast agent pooling, CAP sign. It occurs when contrast stagnates in the venous system due to the absence of effective circulation and serves as a radiologic marker of cardiac arrest. The SVC IVC level sign refers to the dependent layering of contrast in the inferior vena cava. Retrograde opacification of hepatic and renal veins may also be observed. The absence of pulmonary arterial enhancement confirms that the circulation has effectively ceased. Prognosis and outcome. In this case, the arrest was recognized by the radiographer during the scan. Despite immediate resuscitation efforts, the patient unfortunately did not recover. This highlights the extremely poor prognosis associated with the CAP sign and reinforces the need for vigilance during contrast-enhanced imaging procedures. From an educational standpoint, several key points emerge. Always verify vital signs before initiating contrast injection. The combination of absent pulmonary opacification and reflux into the IVC should raise immediate suspicion of cardiac arrest. The CAP sign is a critical radiologic red flag indicating imminent or ongoing cardiopulmonary arrest. Radiology staff must be trained to recognize these findings and promptly alert the resuscitation team. Thank you for joining us today. Stay tuned for more exciting educational clips, and don't forget to follow the CT Scan Academy for more valuable learning content. I'd love to hear your thoughts about this case. Please leave a comment below. If you enjoyed this video, make sure to subscribe and feel free to share your suggestions for future topics.